I'm Dr. Shilpa Gupta. I'm a genitourinary medical oncologist at the Cleveland Clinic, Taussig Cancer Institute in Cleveland, Ohio. And today we're talking about the molecular therapeutics for advanced bladder cancer. We've really made a lot of progress in the last 4 or 5 years with these novel drugs for patients who have had prior chemotherapy and immunotherapy or either or, and especially notable are the advances with the first targeted therapy which targets a mutation in bladder cancer called FGFR. And erdafitinib was approved a few years ago for patients who harbored this mutation in their tumors, and it led to remarkable responses and clinical outcomes, especially since after patients have had immunotherapy, we really did not have a whole lot of choices, and immunotherapy doesn't work in everybody. In fact, it only works in about 20% of patients. And the other class of drugs is the antibody drug conjugates, which are really unique agents, and they have an antibody and the linker, which makes it all, very effective therapies. And the two antibody drug conjugates that we now have approved are enfortumab vedotin and sacituzumab govitecan, which have been used in patients who have had prior therapies, including chemotherapy and immunotherapy. Enfortumab vedotin has full FDA approval for patients with progression on any one prior line of therapy, and sacituzumab govitecan has accelerated FDA approval in patients who had prior platinum chemo and immunotherapy. So immune checkpoint inhibitors, we've seen that in bladder cancer, for example, really we don't have a good biomarker to select which patients may benefit from that therapy. Although in the past there was thought that high PD-L1 expression makes patients respond better. We are seeing more and more that PD-L1 has not panned out to be a great biomarker. So at this point, anybody with advanced bladder cancer who progresses on platinum chemotherapy can get checkpoint inhibitors. We have shown some work that high tumor mutational burden can potentially serve as a complement to clinical decision-making for patients who are not candidates for cisplatin-containing chemotherapy in the frontline setting, and can help whether immunotherapy or carboplatin-based chemotherapy is the better option. But in terms of how the molecular therapeutics are different from immunotherapy, I think the highlight is that these agents are effective even after patients have had immunotherapy and progressed. And for example, the FGFR inhibitor, for that, if patients harbor the mutation, they could have had one prior line of therapy and can be treated with this agent. And this many times patients are not fit enough to receive chemotherapy. And if we are able to give these targeted agents, that really creates an additional option. Same goes for the antibody drug conjugates, which can be given to patients who may not be candidates for chemotherapy. So at this point, for the FGFR inhibitor or erdafitinib, the key criteria that we need is the presence of the alteration or mutation or fusion in the tumor for the patient. So that's one of the features that is needed for the drug to work. And besides that, patients who are able to swallow the pills and don't have any other issues, and I think those are the key factors. Those agents have a different set of toxicity profile. which is very different from chemotherapy, but it still requires monitoring, especially their phosphorus levels. Sometimes patients can get ocular toxicity, so we need to team up with ophthalmologists, and so it's a whole team effort for those agents, even though it is not traditional chemotherapy. For antibody drug conjugates, I think the key criteria is, progression or prior immunotherapy or chemotherapy. However, these drugs can also have a lot of side effects, even though they may be different from traditional chemotherapy. For example, enfortumab vedotin has side effects of rash, which can be very severe, and peripheral neuropathy, which can be severe. So in patients who already have, let's say, grade 2 neuropathy, we would be cautious about using it, or, adjusting the dose or giving them a treatment break. As far as the other antibody drug conjugates, sacituzumab govitecan goes, the side effect profile is different. It can cause life-threatening neutropenia, neutropenic fever, or diarrhea. So we have to be very proactive with use of growth factors and antidiarrheal agents and close monitoring. So I think the patients' comorbidities do determine this, presence of uncontrolled diabetes, for example. We see instances of diabetic ketoacidosis with EV, so we have to just be cautious and, monitor these things closely. So I would say that based on patients' comorbidities and the toxicity profile of these individual agents, we would select what to use first. Ideally, we would want to use all these agents in some sequence.